But like which happens with most of our diabetic patients, the control wanes off after some time, sometimes because of the drug, sometimes because of the physician, sometimes because of the patient. This patient is now on currently 16 units of degludec or Tresiba. His HbA1c is 8.3, similar. His fasting glucose is good, but his postprandial glucose is rising. Difficult to control postprandial glucose, like in most Indian settings with high carbohydrate diets. And we now want to know that this postprandial glucose will obviously not be taken care of by the degludec. We want to add a prandial insulin, an insulin before a meal to check his postprandial glucose rise. But he's concerned that since his lifestyle is a little erratic, he does not know at what time of the day will he be taking the insulin depending on the meals that he's taking. He does not know when he takes lunch, whether his lunch is the biggest meal of the day or the breakfast or the dinner, and he has a lot of complexities in terms of the prandial shot that we might be advising him. So Soumik, my question for this person or this case who now has a difficult to control PPG is to which prandial insulin will you consider in this case scenario who already is on degludec?
So when considering the basal insulin, we considered flexibility, we considered a lesser risk of hypoglycemia. We put in the same criteria when we are considering the prandial insulin as well. So we need an insulin which, unlike the conventional insulin, is rapidly absorbed, can be possibly given even after taking the meal, and gives you a lot more flexibility with good control, or if possible better control than the conventional one, and a lower risk of hypoglycemia. Do we have one such? Yes, we do have one such. And I'm not talking of an insulin which is better than a regular human insulin. We actually have fast-acting aspart, which is better than conventional aspart. This is data from the OnSite 1 trial, which was a randomized control trial, which showed that if you used faster-acting aspart, you got better postprandial glucose control, both at the 1 hour and 2 hour post-meal time point. And this, of course, is not that study, but a different one, presented at the EASD meeting, which showed that over the 2 to 4 hours post-meal period, the rates of hypoglycemia were lower with fast-acting aspart compared to conventional aspart. So better immediate post-meal glucose control, less delayed post-meal hypoglycemia is what this gives you. And on top of that, flexibility is there, because this insulin can be given as quickly as immediately before a meal onset to up to 20 minutes after starting a meal. And even if you give it 20 minutes after starting a meal, there is no increased risk of postprandial hypoglycemia with similar glucose control. So it gives you flexibility. So we are talking of two different insulins, both of which give you flexibility, both of which give you possibly superior glucose control in a real world setting with degludec in a randomized control trial with faster acting aspart, and both of which carry a lower risk of hypoglycemia compared to the other insulins that are comparable. So let us look at the next patient. We have a 53-year-old businessman, Mr. Ramesh, who is again obese by Indian standards. His blood pressure is 132/86. He has diabetes for 12 years. Our earlier patient had diabetes for 7. This patient has diabetes for 12 years. His A1C is quite high, has crossed the 10% point. His fasting is 150, postprandial is 280 milligrams per deciliter. He is on 4 milligrams of glimepiride, 2 grams of metformin, and 10 milligrams of dapagliflozin a day. So again, this time I ask him again, which insulin would you consider in this scenario?
So like our previous scenario, this patient also has poor glycemic control. His fasting is also uncontrolled. His BP is uncontrolled. He has an HbA1c of above 10, so immediately qualifies for insulin, and we will not try to add another oral agent in his case. For him, we can consider adding a premixed insulin, not the conventional premixed insulin, but a better kind of premixed insulin, which will give us the advantage of the last 2 insulins that we discussed. One, a better long-acting insulin, and a better short-acting or immediate-acting insulin. For the long-acting, we again have degludec or Tresiba in this case, and for the short-acting insulin, we will have short-acting aspartate. Coming to IDEG-ASP, which is available in today to us, and how does it do better compared to the various other regimes which could have been advocated in this case, either compared to a basal bolus or compared to a basal plus regime. Compared to a basal plus regime which has similar efficacy, less nocturnal hypoglycemia, use of one pen only, not more than one pen for different types of insulin, swapping between pens. And for the basal bolus regime, which is considered one of the gold standard of diabetes management because it similars the physiological insulin secretion, it also has similar efficacy, less hypoglycemia, lesser dose of insulin is required. And again, we often see our patients confused between the two pens of basal bolus. Here there is only one pen of insulin. So this IDEG-ASP or is available as Rhizodec should be the treatment of choice for initiation in this case of ours who has both difficult fasting and prandial glucose controls and has grossly deranged hyperglycemia. So my question goes back to Soumik is, why consider this combination IDEG-ASP at initiation in this case of ours?
So again, I think in patients who have missed the bus, either because of physician inertia or patient inertia, where when you are initiating insulin, you are in a scenario where the fasting is high and the postprandial is higher, where you need control of both to reach your A1C targets. And again, it's important to control postprandial because for a given fasting glucose, postprandial glucose independently might determine the risk of vascular complications. You need to target both components. And as we were discussing over the last 10-15 minutes, possibly the best basal that we have today is Degludec, and one of the best short-acting insulins or ultra-rapid-acting insulins that we have is fast-acting aspart. So we don't have fast-acting aspart here, but the conventional aspart with Degludec in a single co-formulation, possibly the only insulin available which acts over 24 hours as well as targets the immediate postprandial glucose when given before a meal. So if you look at this study which compared IDEG-ASP with a youth 100 insulin. So when you are initiating insulin, it's a bolus versus a co-formulation which is a basal versus a co-formulation which is sort of a basal plus. You have a mealtime component and a long-acting component in the same injection. So naturally when you are comparing these two, you have better HbA1c reduction, predominantly driven by a decrease in the postprandial glucose after the meal before which IDEG-ASP was given. And at the end of the day, as many as 7 out of 10 additional patients attain your A1C goals compared to U100 alone. So you have better glucose lowering. Now does it come at an increased risk of hypoglycemia? So this is a very interesting study, smart study, involving predominantly Indian physicians and diabetologists. There were about 1,000 patients in this study where it was shown that you could be on an oral drug, you could be on an insulin, you simply shifted the patient or added Rhizodec on top of whatever you were on. Of course, if you were on an insulin, it had to be discontinued. Better glucose control was documented with lowering of the rates of hypoglycemia. If you look at the red bar initially, that was the basal rate of hypoglycemia with uncontrolled glucose. After adding IDEG-ASP, after adding Rhizodec, not only did the glucose levels come down, the rates of hypoglycemia came down as well, and mind you, some of them were already on insulin, they were simply shifted to IDEG-ASP. So again, if you have better glucose control, if you have lower rates of hypoglycemia, your quality of life improves, and possibly your rate of continuing on that insulin improves as well, which is very important because insulin is one of the commonest drugs which is discontinued for a variety of reasons. So if you can have a better quality of life, you will think of keeping yourself on the drug, continuing insulin over long. So again, the important question, how to initiate IDEG-ASP, how to initiate Rhizodec.
So this patient of ours needs a premixed formulation among the newer insulins, and we've decided to initiate him on IDEG-ASP, considering the benefits that Soumik just pointed out of IDEG-ASP compared to other basal forms of insulin, basal plus, basal bolus, or a combination with basal insulin. First, most important thing is IDEG-ASP can be administered with the largest meal of the day. If you're taking, there are two scenarios. One, when you give IDEG-ASP once daily, and two, when you give IDEG-ASP twice daily. If the person has one major meal of the day, a lunch or a large breakfast, then it needs to be added in 10 units before that largest meal of the day. But if a person, like many Indian scenarios, have two larger meals a day, some people have a heavy breakfast and a heavy dinner, they are out working during lunch, so they have a working lunch or a small lunch. Some people have a heavy lunch and a heavy dinner. So if there is a scenario like you are having two major meals, then IDEG-ASP needs to be added twice daily with the two major carbohydrate meals of the day, and the ratio has to be split equally between the two major carb meals of the day. So these are the two scenarios where you can give Rhizodec or IDEC acid. Mind it, it's very interesting that a pre-mixed formulation can be given just once daily, comes as another attractive bonus for our patients. And how do you adjust once you've initiated? How do you adjust? Look at the fasting glucose, increase by plus or decrease by plus unless your fasting is within target. And for a patient who is taking twice Rhizodec, a pre-dinner or a pre-breakfast glucose level can be used for adjustment of the insulin dose. So this is how we will adjust the Rhizodec depending on whether you are giving once daily or twice daily to your patients who are having 1 or 2 carbohydrate-rich meals a day. So Rhizodec is a people with diabetes-centric approach. It is an ideal insulin at insulin initiation backed with all the evidence just Soumik discussed, has better efficacy and safety, positive impact on quality of life, and has mealtime flexibility. So that's all I think we have for this presentation with this duologue on newer insulins and initiation of insulin, and we'll be happy to take any questions with my host. Thank you so much.